Okay. Hi, everybody. Welcome. I am Dr. Nancy Jo Williams, and I'm here with several of my friends and colleagues while we're going to start just talking about all things clinical that we love from all our various different perspectives. I'm an associate professor at the School of Social Welfare, and I specialize in harm reduction and substance use and misuse behaviors. And I'll pop it over to Jen.
Hi, I'm Jenn Ma-Pham. I'm a therapist located out in California. I'm currently running my own private practice and I specialize in trauma therapy.
My name is Michael Riquino. I also am an associate professor at the KU School of Social Welfare. I also have a background as a clinical therapist, and I specialize in assessing and treating self-injurious thoughts and behaviors.
So we kind of have the full spectrum
Yes.
of what's
Yeah.
going on. Yes. And so that Michael's going to be our lovely facilitator because he's the best one to ask questions, and then we're going to go from there.
Yeah, so I'm excited to hear your responses and reactions to this prompt that I have for you. So social work students often assert their desire to become trauma therapists. But what does it actually take to become a trauma therapist?
That's a great question. Let me ask a little further. What are these students saying? I don't really interact with students at all
Mm.
in my practice. So what are they saying? I don't have a finger on the pulse of today's trainees. So what are they saying exactly?
So I get a lot of that they want to be trauma therapists and they think that they can learn an EMDR protocol in a one semester course while they're still learning typically how to ask an effective open-ended question at the same time.
Mm.
And I get a little forceful in my response, but we can get to that. Michael, what are you hearing too?
I hear similar things. Yeah, I have students who have not even graduated from the MSW program who believe it possible to graduate, immediately jump into providing trauma therapy, maybe open a private practice. And I'm like, whoa, okay, slow down. Maybe there's a couple of steps that it takes before you become a trauma therapist.
That's so interesting. I didn't know it became such a sexy topic.
Yeah, it's super sexy. We also have at KU we have an elective that talks about kind of trauma-informed protocols. And so it's more of a
Mhm.
survey and an introduction to them with the caveat that they're not learning how to do trauma therapy.
Mm.
And when I was director, some students came to me and they were upset that they didn't learn trauma therapy, which my response was, well,
Ah.
it takes extensive training to be able to manage and handle that level of therapeutic like intervention. Um, and on a not so great day, I might say like, let's work on learning how to like ask an open-ended question and effectively responding and kind of doing some basic like
Mm.
protocols. Um, and get that under their belt first. But trauma, people didn't start asking for this until about 5 years ago. When I was teaching back in the late 2000s, people were really wanting just to learn like
Mm.
CBT protocols. Um, they started asking more for dialectical behavior therapy skills, probably in the past 10 years, and we've integrated some of those,
Mhm.
mindful that we're not a certification program. And now they're wanting a lot of like ACT and like EMDR and wanting to come out and hang a shingle. And one of the issues is different from California and Kansas. People can go immediately into private practice with supervision and be
Mm.
paneled and everything, which means somebody could graduate from an MSW program, be collecting hours for licensure and running a private practice under supervision and claiming on Psychology Today or something like that they're a trained trauma therapist. And I've seen that happen too.
Mm. That's so interesting. Um, I mean, I have very strong feelings about providing trauma therapy. I guess, I mean, to answer your question, Michael, I would say it is a very it's a big responsibility. I appreciate people who want to do it. I would say if I were sitting with a student who, was expressing their desire to be a trauma therapist, I would say start being trauma informed first. Like, do that first. We can be trauma informed in our everyday lives. So do that first. And being trauma informed to me means you understand the complexity of trauma, that you don't look at it like it's some kind of, sexy, interesting topic, but you're looking at the people you want to work with and treat as whole people who've been subjected to traumatizing events, sometimes repeatedly, sometimes just once, but these are people. And I'm an LCSW, trained as such, and it's about seeing the whole person first. And sometimes people come in and don't want to go there. So you start there and you build trust. So basic rapport building using all the really kind of entry level clinical skills. And then you build up with, of course, an undertone of self-awareness to see what are you actually good at, what you might want to work on, or maybe like you pick a certain population because you're passionate about it. A lot of times it's because you feel like you're a part of the population or something. You've done your healing, I hope. And you get to a certain point where you're like, I want to maybe give back or work with this particular group. But first, how's your own journey been? And are you going to be clear that you are not going to cause any damage? Right. So that for me, that's really number one. I took a while before I called myself a trauma therapist. It felt weird to me. It still feels weird to me. I do it more of like an elevator pitch type thing because people ask, what do you do? And I just want to be very clear. These are things I don't do, by just saying the specific thing that I happen to focus on with my clients. But even then, when you say trauma therapy, am I working with, veterans with PTSD, or, am I dealing with people who deal with natural disasters or what? Me personally, you have to get very specific. I work with adults between 20 and 50 years old who have had an abundance of childhood trauma. And that tends to be my, what I'm good at. What you care about and what you're good at may not be the same thing. I would tell the students that too. But it does take a lot of ongoing hard work, and no one semester or one training is not going to do it. And to even have that mindset's not great, I would say. Like, you need to keep on getting trained and continue with your own self-reflections. Never believe you know it all, and keep learning from other people who know how to do stuff that's different than you, and just keep on doing that. I got trained in attachment focused EMDR much later in my career. We won't even get into it, but I didn't even plan on being a therapist. So that's a whole other thing. Um, but that's what I would say. Don't rely on one certification or one training. You have to know how to be with people and create a space so people feel comfortable with you, feel safe, and can trust that you're not going to let them down. And you yourself need to get your stuff in order as a private practice, therapist, to make sure you don't. And I have a few examples of how little administrative things can breach trust and make someone not want to come to you again. But those are things you need to really get a handle of, I would
Hmm.
say. So the basic skills, yeah, you have to get really good at that first.
I like the idea too, and I think I talk about this a lot, which is like if you're so focused on being the quote unquote trauma therapist that you overlook what's involved in it, like that's where I often will like start exploring with a student or a trainee about like, well, what is it you're wanting and why? And and it usually then comes back to, well, like what you're wanting is I think what Jen's talking about being trauma informed. It's like, let's start with like, how are you building effective relationships? How are you assessing whether a client wants to go there or not? And what I see in early career social workers, it's always really hard, is they're like, well, I think they need to go here and deal with this. And I say, well, that's not really your job.
Mm.
And when you take that in a trauma
Mm-mm.
context, Yeah, yeah, it's like a no, no, like that's where you actually start doing harm. And so I get a little feisty with students when they talk about it when I'm teaching practice. I don't know, Michael, do you get like, I think you get equally spicy.
I do. It's something you mentioned, Jen, multiple times with this idea of like having to do your own work and having to be kind of build that awareness of self and one's own past history before you're really truly prepared to work with other people through their trauma. And I
Hmm.
see this a lot. I think a lot of the students who approach me with this question of like, well, I want to be a trauma therapist. How do I become a trauma therapist? It's clear that sometimes there's a lot of like unresolved trauma that they're still working through. And so part of it feels like, you need to slow down first, build up these really
Yeah.
baseline foundational skills before moving into that level of intense work.
Yeah, and I think we're all in agreement that it's not like, oh, you get to some finish line and you're healed from your trauma, and then now you can become a trauma therapist. It's more of no, it's an ongoing process, and you have to make sure that because we have a responsibility, right? If I'm just like a public citizen, just out in the world, going to the grocery store, that's one thing. If I'm a therapist, and when I say I take it very seriously, I mean that I'm sitting with another person. They are choosing to show up raw and vulnerable, and they want to get better. That is a big responsibility. And when I say that, I don't mean we're, gonna overdo ourselves and cross boundaries and things like that, but it's more of understanding the magnitude of what you're about to do every time you sit down with somebody and know that they are choosing to take this huge step in therapy of looking into all the things that are not working or all the pain they've gone through. And you have to understand it at a human level before you start thinking, let me just reach into my pocket and pull out this modality and follow this protocol. It's like it's very nuanced. You have to know how to be with people.
And what I appreciate about watching you and your career, Jen, I think too, is like you're a licensed, fully clinically licensed. You've been practicing for a very long time across various contexts, and you're still seeking out training and supervision as you're conducting this work.
Oh,
And
yeah.
like, and I think people also think, oh, well, I'm licensed and like, but there's the intensity of the work that you do with your clients means that you're doing ongoing like group level supervision to make sure that you're staying on track too. And I think that at the early trainee level, we don't always emphasize how much it's like there's no, I mean, Michael and I have done that as we watched our classes, like we'll emphasize like there's no endpoint where you like get this. Like it's like, yay, I no longer have to figure it out. And so
Oh,
yeah.
unfortunately, the trauma gets more and more interesting, doesn't it?
Yes.
Yeah, we're talking individualized childhood, then we talk about, career level and then societal level. I mean, it just keeps on keeping on. There's all
Hmm.
kinds, all kinds. Like one of the interesting things about, for example, the trainings that I've gone to, even the training when I started mine, which is multi-year, and then ongoing supervision is that they start adding more protocols, including a recent traumatic event protocol to kind of their general protocol because we start experiencing a lot of traumatic events. People at the institute I train at were called upon to show up after school shootings and incidents like that to help people make sure that that particular incident didn't get locked into their nervous system. I mean, the world keeps changing and we have to keep adapting. And as much as there's joy, there's trauma too. We just have to keep getting, polishing our knives. I don't know.
Yeah. Well, and I think
Sharpening them? Is that the saying? I don't know.
polishing.
Sharpening them? Polishing the tools? I don't know.
It is. I mean, I think also from like a training perspective, it's one of the things we're always trying to like emphasize early career wise is like there's like it's important to slow down to really make sure you get to where you need to go. And by the time you slow down and figure that out, that you start realizing all these things, right? Like it is a part of that process.
Hmm.
And that there's no And one of the things that Michael and I know we've struggled with is when you're training somebody early in their career, we will sometimes purposely hold back more nuanced details that are like, well, you can specialize in this way and this way and this way, because it's like overwhelming to think of the vast array of trauma that you're talking about and how like you
Mhm.
specialize in a specific area, other people do different things. And which is interesting because like it makes me think off the top of my head, like when somebody comes to me and they're like, I'm gonna be a trauma therapist, it's like one of the things that I have to often do and slow down is to explore with them like where it's coming from, like what exactly do they mean when they say
Mhm.
trauma? And
Mhm.
sometimes I'll immediately jump to like, oh, that's a lengthy process. But if on a good day I'll slow down and be like, what do you think trauma is?
Great
And
question.
And we built in like where we talk about trauma focused CBT with young children and their caregivers.
Mm.
And the thing that I find every year when I teach that I'm most surprised by is just clarifying that somebody can experience a traumatic event and not experience traumatic symptoms. And that
Mhm.
that protocol is for the children who experience the traumatic symptoms when they arise. And they're
Mhm.
like, and so having students even disentangle what is trauma versus like symptomology,
Mhm.
um, makes me realize how much the word is so popular, but the actual like deep level understanding of like when you intervene and why you intervene actually is not common knowledge.
Mm. Well, that's why, right, when we're talking about getting your basic skills together, you would know, right? You would, the hope is that someone starts in our field and they start a private practice and that they know how to be with clients and not push them. That's the ideal. Like, who are we? I have a funny story. I worked with a client who was dating, and this client went on a date with a life coach who thought that it was his job to dig into all her unresolved trauma. Do you know the rage I felt when they went on a date? She comes back, she tells me she's completely suicidal. He basically did the whole, oh my gosh, this is so interesting, and just dug in and dug in. By the way, as a life coach, not even, I mean, we're not going to even get into it, but they're on a date, and this is what he decides to do. She ends up hospitalized. How irresponsible. How absolutely irresponsible as a human being, as a life coach, and whatever else he was certified as. I mean, it's just that's what we want to avoid. This is not your place because you're a therapist. You're not there to take care of people wholly. That's not your job. And it's not your job to be with them when you've dug up all this stuff because you think it's a good idea, but the client never gave you an indication they wanted to go there. And then they have to live with themselves and their past and whatever it means for their future. And here you are like, well, on to the next client. That's irresponsible. It's absolutely irresponsible. And why I think therapy, a lot of times I have heard in my career from people who are not familiar who say, like, oh, so you just listen to people, vent all day. It's like, actually, it's a very technical process. It's an incredibly technical process. I'm listening and doing assessments constantly, and I may track in my head a number of things. And so, one of the things that we do in my training is you formulate a trauma timeline. For example, what happens 0 to 5, 5, 6, 7, 8, 9, 10, and go through their lifespan. And you track all the different traumas. But I'm not sitting here digging into everything if they don't initiate it. But I have a trauma timeline in my head, what might be going on. Right. So I have this running log at all times of what they're going through, what they're saying to me, what modalities might work for what's going on. All this is happening while you're still holding space for somebody. That's the skill you better get good at. Oh, and not to mention writing your notes, billing on time, and all these other technical things. And you do it while holding space. That's what people need to get good at first. And so do Do you take yourself to trainings because it's of interest to you? Yes. But don't walk away thinking you're going to know everything because you never will know everything.
There have been a couple of times when you mentioned this idea of, and Nancy touched on this as well, that part of that process is just even learning what trauma is. You identified a bunch of different types of trauma. I'm curious then, when you're talking with your clients, for example, if we think about that, say, psychoeducation process, you may
Hmm.
have been kind of like constructing that trauma timeline in your mind, but they may not even realize that a lot of their experiences truly fit into this category of trauma. How do you
Right.
how do you gently
Yeah.
approach that, as you said, without like digging into it, which isn't helpful?
Timing. You have to get good at timing. Um, I will tell you almost every single one of my clients, I will confidently say over 90%. When you do the general assessment in the beginning and you do all the basic stuff, there's like if you're trauma informed, there's like a trauma section. You ask a client outright, hey, have you experienced any of these things? Most of them will say no. And then you work with them. And then you talk through things. And especially if you're dealing with developmental trauma, you will find out they start reporting stuff and you're like, oh my God, that is so traumatic. In your head, this is like, talking to yourself. But they think it's completely normalized in their childhood. Oh, I was slammed up against the wall a couple times, when I was late on my homework or I didn't show up to dinner on time. In your head as a therapist, you're thinking that, how terrible is that? Based on your relationship with the client, based on what you know about their readiness, based on the kind of rapport you have, it really depends. Someone might be new to me and say something like that, and I would say that sounds really awful for a 5-year-old to experience. Or I might have had a 3-year relationship with you, and I'll look at them and I'll say, you and I both know that's not okay. And then you should go, yeah, I realize when I say it out of my mouth. Like it's that kind of thing, but you get it all the time. You get it all the time, and people don't actively, it's part of the neurological trauma response too. So many times when I'm doing attachment focused EMDR, as people are tapping, so it's part of that, intervention, they start remembering incidences. It's not like they forgot, but they didn't think it was a thing. Oh, I got pulled over by this state trooper and I was terrified. I'm like, oh, we never talked about that. They're like, I didn't even really remember, but I guess my body did. Right. But my client's able to say that because I've done psychoeducation about the effects on the body. We've done a lot of psychosomatic work. We've done so many other things for the client to say, oh, yeah, I remember that now. And so, again, rapport building is so important. But you find these opportunities, you work in your personality, all these kind of things to help people understand, oh, that was not okay, that thing that happened to me. Then you dig deeper, you're like, for that's not okay for any 12-year-old to have that bullying from a teacher, or you do all that, and that's a trauma informed piece before someone's ready to say, I'm going to dig into that now.
What I like about this is that you're also talking about like how we learn to do the skills as therapists is also kind of like how clients learn how to scaffold and build up their skill set. So first it's like, can you sit with me and trust me? Right? And that's kind of one of
Mhm.
the first things we teach students. But then there's also like, can I also work with you to like teach you about kind of the basic components of how this works, like psychoeducation and getting really good at psychoeducation. And I think, I mean, Michael and I both love psychoeducation, so, but it's, sometimes it's a thing where it's like, oh, well, that's not sexy or interesting. You're just like teaching people basic skills. And it's like, dude, that's really important. It's
Yes.
so important. And then teaching people to like, in your modality, like resource or like find ways to like self-regulate and self-soothe and make sure that they're able to handle the distress before you even dive into the trauma. And so
Mhm.
there's, it's interesting because like I hadn't really thought about it until I was listening to you talk about like that's how we often will teach people how to build their own skill set is the same unfolding of how we build it with clients.
Mhm. How do you build trust? How do you engage people? How do you teach others what's going on in your own head? So let's assume you have a brand new social worker, graduated, they want to get into private practice. They know a lot about something, but do they know how to talk about it? Do you know how to engage others about it in an interesting way, in a non-threatening, judgmental, boring way, so that your client sits there and goes, "Oh, this is interesting. Oh, I think that applies to me." You have to get good at that. This is the whole thing. If you have no pizzazz, what's your brand? You know? What's your brand? It's a business. If this is a business, you're running a business.
Hmm.
Yeah,
Start, yeah.
I often talk to students about like that pizzazz piece that you described, where in my mind, psychoeducation is about being able to artfully and skillfully weave in information into a human conversation. It's not about,
Yeah,
okay, and now I'm going to teach you about the symptoms of
right.
PTSD as outlined in the DSM. And so it's like, oh, as you said, like making like that sounds like a challenging experience. So like nobody should have to experience this. And then you just
Yeah,
kind of like weave in these little
yeah,
pieces of education.
yeah. Assume the best of your client. Assume that they know more than you do because this is their life. But then weave in these things so they go, huh, I didn't think about it like that, but I've thought about it for a while. But you have to be captivating. You have to be interesting. You have to be all these things. But hence the work on yourself. My hope is that we have so many different therapists that do so many interesting things that there's somebody for everybody. That's my hope. And because I'm not for everyone and not everybody is for me. It's the same thing, right? It's like a mechanic. Do you work on Porsches or Hondas? Do you do motorcycles or big, delivery trucks? They're all different. They're all different. So, figure out what you're good at and then hone in on those skills and then build your brand.
Which speaks to this idea of like in your early career development, doing your own work so that you can be honest enough with yourself where your talents lie. And I think I remember early on, Jen and I trained together. And so like early on, like if you
Mm.
asked 25-ish-year-old us, like what we thought we were going to do with our MSW careers, what,
Oh,
like almost 20 years ago, I if we would look at our present day selves and be like,
20
so
years ago. Yes,
is
ma'am.
it 20? Yeah, I
It's
think
been 20 years since we were in graduate school.
yeah, it's been
Yes.
exactly 20 years actually.
It's been exactly 20 years since we were in graduate school. And yes, yes, absolutely. Would never tell you I'd be this.
And I would never tell you to
Nancy
be
knows it.
this. Yeah, but like so
Yes.
it's like in the process of doing, we learned our strengths, which were surprising for us. I think we're more surprised of our own strengths than others, right? Because that's how we are
Yeah.
often as just like social people who are drawn to the field, but
People.
like just humans. Wonderful humans. But
Mhm.
but the process of doing and being in the world and working with clients and taking on roles that may be more contained. Like I did a lot of like screening and like referral to treatment and brief interventions and while there are lots of things I have strengths in, where I ended up and where I specialized was not necessarily where I initially thought my strength. I think I thought I was going to work with kids. And
Oh, really?
yeah, yeah. I think I like when I
We built
first
our
started.
friendship on just like friendship stuff. I had no idea.
Yeah, I thought I was going to work with
Really?
teenagers, and then I quickly learned that
Whoa.
it was not my jam or my strength. I mean, now I think I
I'm
do
good with
better.
teenagers.
You're
That's so
very good with
random.
teenagers. Yes,
But
yes.
I still choose not to work with them. You know
Yeah,
why? I know my limits
yeah.
because teenagers love teenagers. Totally get along with teenagers. Teenagers, for me, again, talking about knowing your limitations, for me, they are still at a point in their lives where they are dependent on their adults. And a lot of times their adults are the problem. And since I cannot be treating the adults and I'm trying with the teens, that's my limit. I can't do it.
Yeah, that's
I
that's a
can't.
that's a
I
real honest statement. I would agree. That's your
can't do it.
But
Can't do it.
whereas like for me, I do really, really well with like middle-aged to older adults, which was not what because I like I have like a softer face. I read more friendly, like I'm nice and open. Like I often remind people if they're like grandchildren, if they don't hate them. Like, there's these so there were things where there was one, Jen was a clinical director once, and there was a client, and she wouldn't answer the door, and I like knocked on her
Oh,
door, and she opened the door, and when I asked her why she decided to meet with me, she was like, "Well, you just have this like hospitality face. It's kind of like squishy." And like,
yeah. Yeah, I
and
remember this client. She was funny. I remember this client very clearly.
yeah.
She when I was the director, she finally was open because she said, "You're competent." I remember she looked at me and she said, "You're competent unlike the others."
So Jen was competent, and I was friendly.
And she was friendly and she let Nancy in.
She
And
let
you
me
know what? What did Nancy do? Nancy talked to her just about her life. She didn't dig into her trauma. She talked about when she was in her 20s and partying and what that was like and where she would go. They built rapport for a while.
in.
And
But
that's
the
what's needed because,
Yeah. But the goal of that services was about stabilization and housing. Like with women who are often 50 plus, it wasn't about healing their life trauma. That wasn't the scope of my role. My role was like, what do we need to make sure you're connected to your services, that you're compliant with your meds, that you're like, you know, in some cases, like that if you're gonna smoke, you smoke downstairs and not in your room. Like, like there was a lot of like
Yeah.
harm reduction we were doing. And it leaned into my skill set 'cause it was like, how do we make sure you stay housed, right? It wasn't like, how do we make sure you're like dealing with, often in cases for a lot of the women, 50 plus years of ongoing chronic experiences of several layers of different types of violence. And that we weren't going to crack that. And it wasn't my job. And trying to like, and I think that's where we worked well was I was like, I wasn't trying to crack it. Like it was that wasn't the goal. And I
Mm-mm.
think but in the early 2000s, like we were taught, like sometimes you don't crack open the trauma if you don't have the skill sets or you don't have the time and capacity with them. In addition to whether
Right.
like, and I think that's what I liked about our training was that we were able to say, I'm not the person to do this with.
Yeah. And maybe this is not the time, but we have
Mm-hmm.
it when you're ready and you want to.
Mm-hmm.
you know? But yeah, but when I say, doing actual in fully engaged trauma therapy versus just being trauma informed. So, in bringing up that example, there was another woman, also 50 plus, older, a litany of trauma in her history from what we've gathered from different case managers over the years and things like that. When I became a director, at some point, her mother died. And everyone's like, oh my gosh, her mother died. Oh no, it was so sad. And I was like, what makes you think she might be sad? This was one of her abusers. Stop assuming. Be trauma informed. See what she has to say about it. And sure enough, I remember being in this particular staff team meeting, and I said that, and people were like, "Oh," because we had a lot of young new social workers, and I'm like, we are typically trained if this is, grief and loss, bereavement work. This is how you talk about it. I'm like, nothing says this client just because we have this intel wants to do that, needs it, or wants it.
She
And I
didn't want it,
remember
right? I think
she didn't want it. She didn't want it. You remember, yeah, she didn't want it. And I remember she walked past me because all these ladies would talk to me, even though, I wasn't their clinician because they knew I was the director. And she was like, why does everybody keep asking me about my mother? And I said, this was my opportunity. I was like, people get, have strong feelings and complicated feelings about death, but it doesn't mean you have to really care about what just happened with your mom. And she's like, I don't. And I was like, cool. Just kept it moving. I was like, well, hey, if you ever want to vent about anything, you let me know. But you know what? If they bring it up, you say, hey, I don't want to talk about it. Doesn't affect me. I want to talk about this. I'm like, you can do that. She's like, okay. I remember her just kind of walking on. And that's what being trauma informed is. Would I call that trauma therapy? No, but that's trauma informed work, you know?
This is actually a really helpful conversation for me too, because I think that like that distinguishing of like those baseline skill sets still loop back, right? So that's one of the things that I'm always I thinking is like it's not like you learn these baseline skills and master them and then they just go away. Like they're like the foundation for everything and you keep
Mm-hmm.
building. But then also like I think we don't always do a good job in training about explaining the difference between trauma informed and building those skills and building up the awareness before you do very specialized postmasters training, which I would say is then more of like the quote unquote trauma therapist. And I'm curious actually, like Michael, like if when students are saying I want to be a trauma therapist, if they're actually conflating the two between being trauma informed in their approach versus actually like trauma specific therapy.
Mm.
Yeah, I think you're absolutely right. I see multiple categories of students, but I was thinking about the students who are kind of the opposite end of the spectrum. You know, the ones who are like, I want to be a trauma therapist, but maybe don't yet have those don't have a trauma-informed understanding. Then there are those who maybe actually have a little bit of a trauma-informed understanding, and they run into situations where they're like, oh crap, shit, I think I just like cracked open this trauma and I didn't mean to. How do I put it back?
Mm.
I guess I'm curious in your experience, Jen.
Oh yeah.
What would you recommend to a student in that situation where like they have a little bit of that trauma-informed understanding, but they're not yet
Yeah.
ready to actually personally intervene on the trauma, but all of a sudden like they've cracked something open that they're not ready for. What do they do?
And when you say cracked open, you mean the client has now just
Yeah.
said something. It's like a, oh, this
They're
is
like
this
they're
is a
like
thing.
yeah, they're like you're so nice and I trust you and I'm gonna tell you this big thing. And then the
Ah.
more aware like trauma informed students who have kind of a natural tendency, they'll be like, I didn't know that was gonna happen. Which is adorable because like they some individuals are naturally so good at getting other people to
Oh
open
yeah.
up.
Yeah. So I would say for that, it's buy yourself some time. So what I would normally do in that case is like, oh, tell me more about that. What do you mean? What about that thing? How long's that been? How have you been managing it? I lean straight into strengths-based work and resilience and ask them, how have you been dealing with that? And the client will say something like, oh my God, it just occurred to me right now that thing happened to me. And you'll say, oh, that must be really scary. Basic, classic stuff. Hey, let's talk about how do we sit with that now? You're really talking to yourself too. How do I sit with this new thing that just came up? Um, but you're now gonna go, you're gonna log in your brain. My client and I are about to go on a parallel process, and we are both gonna be venturing through how to deal with this big thing that just erupted. And then you close out the session with, hey, what do we do with all this knowledge right now? So you can go about the rest of your day and your week.
That
What are your
containment
thoughts?
piece.
You got
Yeah.
to contain it. You have to contain it.
Yeah,
And
the
you better
containment.
use 15 to 20 minutes at the end of your session to contain it. So
And then
say
go to a
it,
supervision like
and then
immediately.
go immediately to your own therapy and supervision and figure out what that was and what do you do next. But yeah, you do that and say it, a lot of times I remember early in my career, people would say stuff at the very end of session. And sometimes you have to look at, is this like a pattern, right? But they'll bring it up and you say, hey, that was a big one. How do you want to manage that so you can go on with your night? And depending on whatever else is going on, do they dissociate a lot? Are they musing? Are they like, what is it? Then you go into harm mitigation, do that, close it out. But again, you go back to these basic skills that you better get really good at so you can handle those situations. Yeah, go to supervision, figure out what do you do with that big thing that just dropped in therapy and go from there.
I like the process that you're describing because it makes me think of how I could so clearly articulate that with students, where, as you said, using those kind of humanistic skills of like sitting with and then moving into
Mhm.
more of kind of maybe a solution focused or almost a like crisis intervention approach of like, okay, and how do we
Mhm.
help you then continue with the rest of your day? Just because
Mhm.
somebody opened up something doesn't mean we have to address all of it in that moment. We
No.
contain and we seek supervision.
Mhm. Yeah. Yeah.
Which then, but I think it's really interesting because what we're talking about, so this is what Michael and I do, Jen, which is like we're like, ooh, like there's actually these weird ways you can make connections, right? So it's this idea of like and it's one of the things we've been talking about in another kind of completely separate conversation, but like where the mind goes, which is like talking about to a student who's like, I want to do this, to be able to explicitly be like, actually, like this skill, this skill, this skill, and this skill that you're learning, which are introductory skills that are appropriate for like entry level master's students or like masters, like where you're at in your training like those are foundational to the subsequent more advanced training in these ways. And like and I think that's where there could be an improvement sometimes even in my approach because my initial reaction is like, oh no. And I've done that one time and it was like not received well, right? But actually like the kinder approach is to say like, look, like crisis intervention helps you contain because sometimes a client's going to bring something that's too big to handle even in that 50-minute session.
Mhm.
Or, and so containment is kind of an ongoing thing. Safety protocols are an ongoing thing. Like building trust and building this rapport and getting really good at this, like being able to
Mm.
understand like timing and understand when to check in and like pull back, understanding when to check in about like current skill sets they have to navigate what they have while you're managing the fact that like the trauma is much bigger, like we're still using all these skills at the same time. And to be able to use all those in addition to these more advanced protocols, it's what you talked about, which is there's an artfulness to it.
Mhm.
Because what people who aren't trained in this area or who are just, I would say talking to Chat GPT,
Mhm.
um, is that there's most of us are having this ongoing internal dialogue and like tracking and sorting as experts that takes us time to develop. And so, that's always been a fascinating thing to me about early career versus mid and later career clinicians is like early career clinicians will watch us do a demo and be like, how did you know to do that?
Mhm.
And and so actually, like when we do demos for kind of early career trainees, we will contain how sophisticated our responding is. So we'll purposely keep it more basic. And even then, it'll be like, how did you know to respond that way? And because if you make it even more advanced to where we see like what you do in more kind of mid to later career advanced clinical work, it's like it feels like magic.
It's a lot because there's a lot to consider. What I do with one client is different from another
Mm-hmm.
because you have to look at history, you have to look at what are all these different factors going on, right? So if I'm talking to, say, a male who has wounds with his mother, that's one thing. If I'm talking to a young Asian American lady who looks at me like an auntie, that's a different thing because we also talk about being a placeholder, right?
Mm-hmm.
In our work. So what I do with her based on other risk factors is different than what I do with this young man or this older man or this older lady who, might look at me like we're peers. It's different because you have to understand the nuance of what you're doing, that it's coming from you and like what effect it's going to have where use of self, is a
Mm-hmm.
big piece in our field. You have to understand, your particular position in this person's life. Clearly something ChatGPT doesn't do, right? Am I the only person in this person's life right now that they can call if they have suicidal ideation? If that is the case, right? And then there's the business practice piece. I'm going to amp up what I do with this client and amp up my availability to them
Mm-hmm.
versus someone else where, you know what, it's time for the training wheels to come off. They're ready to do this thing. They're ready for, so then I'm going to modify my approach, but I have to know how to do all these things.
Mm-hmm. Which I would like to say to those listening. So like in the Plum Village app, like not app, the podcast, they always talk about
Uh,
like dear listeners. Like it's like to those listening, know
cute.
that a component of doing this is to be cognitively brilliant. Like you have to hold an emotional empathic state and be able to be tracking all this information and organizing it. And to know how through time and building information and making connections to respond to a human being, and that it's not guesswork, but it does take experience and practice, which is why we often start with simpler protocols when we're younger and earlier in our careers. Like, because doing a basic crisis intervention at 25 was more than enough for me and my very
Oh
anxious
man.
self.
Yeah.
I was like, okay, I could do this, but over time we build confidence. Actually, one of my favorite stories was Michael talked about early in his career. He would take like one specific skill and be like, this week, everybody's getting cognitive reappraisal. And he got really good at cognitive reappraisal. And I tell that story for him to students and be like, okay, so this week, what are you guys going to work on?
Yeah. Yeah.
It's true. I still, I'm grateful to myself and my clients that they were willing to kind of sit through that. As I was like, I got to learn how to do this skill effectively across all these different people. So this week is reappraisal week. Next week we'll do behavioral activation or whatever it may be.
Hmm. Oh, years of fine-tuning true motivational interviewing. I remember that.
I
This
love
conversation,
motivational interviewing.
as I've been
Sorry.
listening to this conversation, it makes me think about how, I mean, since trauma is such a big thing, how many conversations we could end up having about this as we're coming to a close. I'm curious if we come back to kind of the initial question of like, what does it take to become a trauma therapist? I'm wondering if there's any other lingering thoughts that the two of you have. Um, Maybe some kind of like recommendations, concise summaries, just kind of parting thoughts on this topic of what it takes to become a trauma therapist.
I think the biggest thing I've learned over the years is you have to get to a place where you realize that like it is not your job to do the work for the client. And it's not your job to tell the client where to go. Um, any desire to control or have that type of directional piece as a therapist, um, sometimes it can be helpful if you're doing like really basic case management or crisis therapy or something like that. But like as you move into these more sophisticated protocols, if you're still finding that tendency to want to control or want to like choose things for the client, you have to immediately like check yourself and start doing some personal work. Because that's where I think the potential for harm arises.
Hmm. I think I'm gonna double down on the business aspect of a private practice, which is get your business in order. What I mean by that is know that sometimes you're gonna work with someone and they might be journeying along with you and doing well, and then they hit one of the big ones and they decide, I don't want to go there. It's their right. And then you do all the proper things and you terminate and you let it go. Do not hold on because you need to make X amount of money that month because you didn't plan well enough. Um, I know about, that kind of anxiety because you're running a business. Also, if you are stretched thin, don't take on a client that is going to end up, you never know. You always want to leave like a percentage of your time that might need to go to somebody a little more because things happen in life. You might work with someone who you thought was a once a week client, turns out to be a twice a week with follow-up text messages client. Like you have to be okay with that. You need to know what you're getting into, especially if you're getting into trauma work, because, it's so unpredictable. I will say, I can't speak about other, specialties, but I will say for trauma, you just never freaking know. And so you have to get your stuff in order. You also have to be the therapist that can handle these sessions, take care of yourself. You need to be able to make all your appointments. I'm not saying you have to be a robot, but like get it together. Know what you can handle and what you can't. Stop over promising. Don't be the person that like sends out a generic letter to everyone about your rate increasing. Don't be that person. Like, don't do that. Stick to your word, good business practices. How do you want people to treat you in a business setting? Do that at minimum. So I'm very transparent with my clients. I have a system for sliding scale that's almost feels like lottery. So I'm not the one who's making the decision. It's whoever's in a slot. And if that slot clears, it clears. I have no control over it. That feels good to me. But these are the things that people need to think through, right? So you don't want to say, oh, I'm so desperate that I'm going to do XYZ and then overextend yourself. And then that bleeds into your work. I hear too often about experiences with bad therapists. I had them myself. I remember early 20s, maybe I was even 20, 21 or so, sat with a therapist who I wanted to work on my trauma history. I was coming out of a real bad space and she fell asleep on me in session while doing EMDR. This therapist reclined in her recliner and fell asleep. Come on now. Now, why are you working with me if you've fallen asleep? Get it together. Get it together. Don't do that. Don't do those things. Don't be taking calls in your car. Don't be running late to stuff. Don't, just don't. Don't do those things because you're causing more harm. And unfortunately, I hear too many stories before a client comes to me. Oh, this happened. I was talking to a therapist who didn't know how to work her Zoom, and then she started doing her makeup. What are you doing?
I love that. We're going to end with like, get it together,
Get
guys.
it
Get it
together.
together.
Get it together.
All right. Thank you all for this lovely conversation. It's really nice it's got me thinking a lot. So
Looking
I'm
forward to the next conversation. Lots
I
of
know.
places we can take this.
So many places. Thanks for your time, guys.
All
It was
right.
a pleasure.
Bye.
Bye.